All right, respiratory part two. Talk about some of the causes of dyspnea, and this is the word for short, big fancy word for shortness of breath. Dyspnea, spelled dyspnea. Most time you hear it pronounced dyspnea. I don't know which is right, to be honest with you. I call it dyspnea my entire life. So I'm not going to argue that. Anyways, I highlighted this section because I cannot stress this enough. Anybody who is short of breath, who has an altered level of consciousness, once they start to get lethargic, which means they're slow to respond, they get real heavy-eyed, and they're just really struggling, those folks are in severe distress. They are not just in respiratory distress, they are approaching, if not already in, respiratory failure, because their respiratory drive has failed to provide them enough oxygen to keep their brain functioning like it should. So that is an absolute emergency. They need high flow oxygen and probably assist their ventilations to be able to bring them at least hopefully back around. I have in my career, I've seen people that were like that were just absolutely struggling to breathe, and you start assisting their ventilations with oxygen, and in just a few minutes they've completely turned around and they're awake and probably fighting the bag mask. If you're using a bag valve mask, they're fighting it off of you because they feel like they're being smothered. So there's this back and forth that sometimes you have to do. If those circumstances, if they're awake enough, if you wake them up by using a bag valve mask and their level of consciousness is good enough, you can switch them over to a CPAP. But remember, CPAP is contraindicated in somebody who has an altered level of consciousness. Think of it this way: they may throw up, and if they throw up, they need to have the wherewithal to grab the mask and pull it away from themselves. Otherwise, when they go to throw up, they're just going to aspirate. So when they throw up, that pressure is going to push some of that back down into their lungs, and aspiration pneumonia is very, very bad. It's hard to come back from, especially in the older population. So keep that in mind. While I'm talking about CPAP, the other contraindication to that is hypotension, and I'll get more into that later on. So some of the different things that can cause dyspnea is pulmonary edema, fluid on the lungs that can come from congestive heart failure. It can come from several other things. So anytime there's fluid on the lungs, that can cause shortness of breath. We cover hay fever, obviously, can do that. One of the things, pleural effusions, obstruction of the airway. We'll talk about that with foreign body airway obstruction, whether it's a total or partial airway obstruction. Anytime the bronchioles constrict instead of dilate, anytime they constrict, that can cause the shortness of breath. Hyperventilation syndrome, that's another one that we run into. And in that case, they're not actually short of breath. They are just hyperventilating. They're breathing too fast. So when they do that, they blow off all the carbon dioxide that their body needs. So now they're just completely saturated with oxygen. And that is one that will cause pretty significant symptoms. It starts with tingling around the lips, fingers, in the face, and it can progress to pretty severe cramps. Their hands will start cramping, and I've seen it where like their entire body starts to cramp up from where they've breathed way too fast. The treatment for that, you just want to do the best you can to convince them to slow their breathing down. And what I have found works really well, and I've talked about this before, about remaining calm. Remember, you have to be the calm in the storm. This person is hyperventilating for a reason. Sometimes it's a panic attack, whatever the case may be. So remaining calm, what I have done is get down eye level with them and basically right in their face, as calm as you can. Talk to them. I need you to slow your breathing down. Look at me. Focus with me. Breathe in through your nose, out through your mouth, and just talk calmly and do the best you can to try to get them to slow their breathing down. Environmental and industrial exposures, that's when we're talking about like organophosphate poisonings and things like that and they cause all kinds of other issues as well. Carbon monoxide poisoning is one that we talk about, and the interesting thing with carbon monoxide poisoning is the hemoglobin, which takes up the oxygen, it prefers carbon monoxide over oxygen. Not sure why that is, but the problem is there's only so much room on the hemoglobin for these molecules to attach. So once they get in carbon monoxide or they get into the carbon monoxide and the carbon monoxide attaches to those areas, there's not many places for oxygen to attach. So they will become hypoxic even though their skin color is, they may be flush red in the face. Your pulse oximeter may misread, because with carbon monoxide it still picks up the oxygen, but you're not able to really see carbon monoxide without using an actual carbon monoxide tester, which is pretty much the same thing as a pulse oximetry. It looks just like a pulse oximeter. Some of the monitors now have carbon monoxide testing that you can slip on the fingers and test for carbon monoxide. So that's one to keep in mind. And then with drug overdoses, specifically, we look at narcotics overdoses, things like heroin, morphine, fentanyl. Those are real popular overdoses. Generally, when we see these, the patients have slowed their breathing down significantly because the way the narcotics work, they'll have pinpoint pupils, and it's not uncommon for them to only be breathing 2, 3, maybe 4 times a minute, unresponsive, and those patients can very quickly get into severe distress and even death because they're not breathing enough to sustain life. Any circumstance where we have a shortness of breath and their breathing is not enough to sustain life or to maintain their consciousness, the bag valve mask is a go-to for that. High flow oxygen at minimum, which is a non-rebreather mask at 12 to 15 liters to be able to provide the oxygenation for them. And with the drug overdose, that's one that we can actually provide a medication that works. It's called Narcan. You may have heard of that, but we will work on using that. It's given intranasally. It can also be given through the IV, but intranasally is most commonly used and seen in the field for BLS providers and people outside of EMS, like law enforcement. Fire departments a lot of times will be carrying them, and sometimes even patients' family members will have Narcan as well. Talked a little bit about this, just simply, and I mentioned it in another video, anything that reduces the oxygen flow or the oxygen exchange can cause your shortness of breath. So several things on there that you can read. Mentioned pulmonary edema and congestive heart failure. Congestive heart failure is where one side of the heart's not pumping as hard as it should be, and what happens is some of the fluid starts to back up into the lungs. When we talk about the cellular respiration, remember the use of oxygen, where oxygen takes up and converts glucose into energy. The output is fluid, it's water and carbon dioxide. So that water can sometimes start building up in the lungs, and that will cause congestive heart failure. So what we call congestive heart failure, they will have a common one of the things that's very common with them is called orthopnea, which is the difficulty breathing when laying down. These folks are common to sleep on multiple pillows at night. Sometimes won't even sleep in the bed. Sometimes they will sleep in a recliner because when they lay down, they cannot breathe. Kellyology on that, think about gravity. Gravity pulls down, so if somebody's sitting up, the fluid that's inside the lungs is going to be pulled down in towards the bottom of the lungs. When they go to lay down, that fluid starts to move up towards the top of the lungs, which makes it that much more difficult to breathe. So with congestive failure, that is one of the things that you'll run into. The congestive failure patients are prime candidates for CPAP. CPAP works really, really well on them. One of the other signs of congestive failure that you will see is called pitting edema, and that is where, especially in the lower extremities, you'll see it around the ankles, the feet, where when you push your fingers, you push on their skin and take your finger away, it will leave an indentation, and that's from the buildup of fluid that is there. There are different infections that can cause shortness of breath, and that the whole thing with that is the infection, whatever the infection is interfering with the body's ability to exchange oxygen. A couple of big ones to look at is croup and epiglottitis. Croup has a very distinct cough that is generally seen with kids. And a lot of times it comes on at night. That is, a lot of times it's relieved by moving them out into a cooler environment. Humidified air works to help with that. Epiglottitis is, again, something that is seen more in pediatrics, but it can be seen in an adult, and that's where the epiglottis starts to swell. This can become a real emergency really quickly if you do any type of manipulating with the trying to put anything in their mouth. The dead giveaway for epiglottitis is they will be sitting upright, leaning forward, and a lot of times they're drooling. The drool is because it hurts to swallow. So with epiglottitis, they will have that. It's not uncommon for there to be some wheezes, but and especially stridor, because that is right at the top of the airway, and it starts to swell and close the airway off. So those, humidified oxygen is the primary treatment for EMTs, and transport. Do not do anything to manipulate the airway. Try not to do anything. Don't stick anything in there. Don't try to do anything that would potentially basically make the epiglottis even madder than it already is. Because if you make that epiglottis really mad, then it swells up even more, and now we've got a complete airway obstruction that you really can't relieve because it's not a foreign body. It is part of the body. And if worst case scenario, those patients will end up getting cricothyrotomies from EMS to be able to create an airway if that complete airway obstruction occurs. Two other really common things seen is RSV, or respiratory syncytial virus. This is something that you'll see in young children, and it is highly contagious. It's one of the things to keep an eye out for. Not a whole lot we can do for it as EMTs. Provide oxygenation, and anytime you can humidify the oxygen, that'll definitely help with any type of airway, especially upper airway issues. Bronchiolitis usually comes on secondary to RSV, and again, generally seen in newborns and toddlers. There's, again, not much that we can do with this other than just provide oxygen therapy and transport them. Pneumonia, talked a little bit about that in another video. The thing that we run into is trying to determine the difference between pneumonia and congestive heart failure. primary difference between the two: with pneumonia, you're going to most of the time have a fever. You don't necessarily have to have a fever, but the pneumonia usually will have a fever. They usually have a productive cough. If the cough is productive, it will a lot of times be discolored, usually either a yellow or green or brown or something like that. Whereas with congestive heart failure, if they have a productive cough, it's usually frothy and it can be pink tinged from blood. So something to keep in mind there. The two sound, as far as lung sounds, they sound a lot alike between the two. The other thing with the congestive failure is you're likely to hear it on both sides instead of just one location over the other, whereas with the pneumonia, it's not uncommon for it to be in a single location wherever you listen, and those are the ones where you hear like the crackles, rales, rhonchi. And as far as we're concerned, really don't need to know the difference, be able to differentiate the difference between rales versus rhonchi. It's crackles. It is completely different than wheezes and treated somewhat differently. So that's the difference between those. You usually run into a test question on whooping cough, and that has, again, a very distinct sound that you may hear, and it has that whoop sound whenever they, especially when they inspire after a coughing attack. Any of the respiratory diseases, any of the respiratory circumstances, we're dealing with airway, and with airway, you always want to make sure that your suction unit is handy, because you may or may not need to suction the patient, and especially like a epiglottitis, something like that, they may need to suction some of the secretions. But again, we're not sticking anything in the mouth. We'll just suction drool as it comes, give them something to drool into. But keeping your suction close by is always a highly encouraged. COVID, we're familiar. You guys are familiar with that, and influenza can cause problems. Tuberculosis, this is one that we are generally concerned about. It is one of the things that we will wear our N95s to protect ourselves from. It has the common symptoms of that, usually fever, coughing, night sweats, weight loss. Anytime they have those symptoms, signs and symptoms, then you definitely want to take respiratory precautions, protect yourself by wearing the N95 because tuberculosis is highly contagious, and that's one of the things that we test for, and I think it's every year you generally get a tuberculosis or TB test. Acute pulmonary edema, this is pretty much the same thing as congestive heart failure. The difference in this is it may come on all of a sudden. It is something that we have termed flash edema, and that is, like I said, it just comes on all of a sudden. They'll be, you may be treating them for shortness of breath or something, and then all of a sudden they just really start struggling. You can hear the fluid starting to build up in their lungs, and that would be the acute pulmonary edema. The best treatment for these people generally is going to be CPAP. CPAP has, puts that positive pressure, and if you think about it, this Kellyology, you think about them, the pressure blowing in, and what that does is it helps keep the alveoli open. It allows them to be able to breathe a little bit. Think about it as you're kind of pushing the fluid back into the circulation. Not really what exactly is happening, but that's the easy way to remember that this CPAP is beneficial for the pulmonary edema. talk about COPD, that is real common. We run into that all the time. These are the patients that, in severe cases, they will have oxygen. They'll have it at home. They'll carry it around with them because their oxygen saturations drop whenever they're not being provided oxygen. They start to develop that barrel chest. I talked about that in another video. They may generally walk around with pursed lips, that where they're creating their own peep, if you will. And the most common one that we run into is emphysema, but bronchitis, people that have recurring bouts of bronchitis, all kind of falls under that COPD, or chronic obstructive pulmonary disease is where that comes in. And these are the ones that will end up sometimes having adopting the hypoxic drive, and we get into that hypoxic drive theory that we've talked about. Again, can't stress it enough. Whatever happens, if your patient needs oxygen, give them oxygen. Do not withhold it because for fear of them stopping to breathe or any of that stuff. So I wanted to highlight these two areas. These really, really important, and I like the way that this is covered, where when we talk about congestive failure, that's fluid on the lungs, they will have a wet sound. And that was one that I did not mention, the wet sound. That's the rhonchi, the crackles. And patients with the COPD or restrictive airway disease, so asthma, they are going to have a dry lung sound, which is the wheezes. So wheezes generally get treated with albuterol, some type of breathing treatment, whether it's a nebulized breathing treatment or an MDI, meter dose inhaler. One of those two will treat the wheezes, and wet sounds generally get treated with CPAP. So that's the two primary treatments. Oxygen is always the first line of choice, and but the definitive for wheezes is some type of bronchodilator, albuterol, Atrovent. Those are things that they may come in a meter dose inhaler, or it may be something that we are carrying and that we provide through a nebulizer. The wet sounds, again, those we provide oxygen to try and help increase the oxygen that they're breathing in, but ultimately to help them turn around, they're going to end up with some type of CPAP, whether it's CPAP or some type of constant positive pressure. It may be BiPAP, which is bilateral, or the two different, you got a different pressure when they breathe in and as to what they have when they breathe out, or constant, which is CPAP, and that's where they're getting a constant push of air. So one of the two are generally your treatment for congestive failure. Your reactive airway diseases, asthma, hay fever, anaphylaxis, that's where the lungs or the bronchi are restricting based on, it's kind of, they're reacting to whatever has stimulated them. For example, my wife has asthma, and she is severely reactive to mold. If she walks into a room where there's mold in the air, in a matter of just seconds, she will start wheezing and end up having to do a meter dose inhaler. Asthma can be brought on by different things, exercise induced. Sometimes certain allergies will create asthma attacks. Those are treated with generally albuterol. People with asthma will have meter dose inhalers a lot of times. If not, we will treat them with albuterol, Atrovent, some type of bronchodilator to try and get those bronchioles to open up so that they can start breathing again. Here where it's talking about allergic rhinitis, rhinitis is a fancy word for a runny nose. Is ultimately what that is. Anaphylactic reactions, this is very important, and I will cover this a little bit more when we talk about an anaphylactic reaction. This is where the body has been exposed to some type of allergen. It could be a new medication that they're taking. It could be a bee sting. It could be shellfish. Those are really common. Bee stings, shellfish, peanuts. Those are some of the more common things that we run into. And sometimes the first time that somebody's exposed to it may not generate the reaction. The second time, once that has gotten into their system once, then their body recognizes it and goes, oh, I don't like this, and it starts to react to it. That you've got mild reactions, and then you get into severe anaphylactic reactions. You have mild allergic reactions, which are the typical bee stings, and you get the swelling around the site. A severe allergic reaction involves 2 or more body systems. When I say body systems, we're talking about the airway, the skin, or the GI tract. So sometimes somebody may be nauseated or have diarrhea or something like that, and their skin changes colors, they get flush, they may get hives on them. That's 2 body systems. They may have shortness of breath and the diarrhea. That's 2 body systems. They don't always have to have the shortness of breath, the swelling of the face, the whelps and all of that stuff. Shortness of breath, swelling of the face, 2 body systems. So 2 or more body systems that are involved indicate the need for treatment, and the treatment is epinephrine. We can give it either through an auto-injector or through drawing it up and administering it, and that's one of the things that we will talk about. So just keep that in mind. You're not just looking for swelling, you're not looking for shortness of breath, you're looking for all of those things. If they're short of breath and they've starting to show some skin color changes, that's 2 body systems. Remember, 2 or more body systems are what we're looking for to want to treat the anaphylaxis. Talk about the pneumothorax. Pneumothorax is where air gets inside the pleural space. We talked about the 2 different linings of the the parietal and visceral pleura. There is what's called a potential space. Those 2 things rub together, and they're separated by a fluid that lubricates them. There is a potential space in there because if something happens and we pop a lung, then air can get into that space. And when the air gets into that space, it has nowhere to go. So it starts to fill the space. And when it fills the space, that starts to cause the lung to start to collapse. So when we talk about a pneumothorax, we're talking about air inside that space that is causing the lungs to not be able to expand like they should. They can get to the point where it becomes what's called a tension pneumothorax, and that's where the the air inside that space has started to fill up to the point that now it's starting to push onto the other side of the chest, and it starts putting pressure on the heart, and then ultimately it starts putting pressure on the other side of the chest. So a spontaneous pneumothorax is typically seen in tall, thin males. Those are the most common people that it happens with. It can happen to really anybody, but a tall, thin male, if you have somebody who just suddenly started having shortness of breath and they're tall, thin, and they've never had a problem with asthma or any of that stuff, be suspicious of a spontaneous pneumothorax. The way to identify that is listen to lung sounds when they have a pneumothorax, also a hemothorax, but that's trauma. We'll talk about that in trauma. When they have a pneumothorax, their lung sounds will start to diminish. So you will not hear the same sounds on the side that's affected. For example, if I'm listening here and I put my stethoscope here, you hear shh, shh. and you come over here and you hear those are diminished lung sounds. Several different reasons that could happen, but if in the event of a spontaneous pneumothorax, that is definitely something to keep in mind. They have those diminished lung sounds. We'll talk more about in the medical side of things. We'll talk more about like the tension pneumothorax and those things. But that's what I wanted to cover with the spontaneous pneumothorax. We're going to talk about airway obstruction when we get to CPR and we do the CPR skills. The pulmonary embolism, this is where a blood clot generally breaks loose. A lot of times you will find it from one of the indications of a potential pulmonary embolus is somebody who has been sedentary for an extended period of time. Maybe they have been on a long trip and they've been sitting. It is somebody that has been bedridden, and this is almost 100% the reason why as soon as somebody has like a hip fracture and surgery on that, they get replacement the same day almost. They're getting them up, walking them around, because you have a tendency to build blood clots from where the blood just kind of sits, if you will. And one of those can break loose, find its way to the lungs, and when it does, it will cause a pulmonary embolus. And with this, it can cause significant problems, even death. The pulmonary embolus will have a lot of times a sharp pain as compared to a pressure pain, usually described as a sharp pain in the center of the chest. Sometimes it'll go straight through to the back. They could have varying degrees of hypoxia, definitely shortness of breath. Their heart rate will be up. Their respiratory rate will be up. So definitely something to keep in mind. Unfortunately, not a whole lot we can do at the EMT or even at the paramedic level other than provide oxygenation and transport them, because ultimately they're going to need some type of definitive care to help take care of that. So that's your pulmonary embolus and what can cause that. I already talked about hyperventilation and kind of what causes that and kind of how to work with that. And in the environmental emergencies that we run into, carbon monoxide poisoning is definitely one that, again, I talked a little bit about that earlier. The pesticides, cleaning solutions, this is the reason why you should never mix chemicals whenever you're trying to clean. Certain chemicals should never be mixed together. Bleach and ammonia should never be mixed together. They put off a really nasty gas that can create respiratory distress, unconsciousness. So those are things you can run into. Pesticides, which is what we talk about with organophosphates. That will end up, we'll talk more about that in the toxicology section, where we're talking about the acronym SLUDGE: salivation, lacrimation, urination, defecation, gastrointestinal distress, and emesis. SLUDGE, that's the common signs and symptoms of an organophosphate poisoning that can lead to seizures, unconsciousness, and seizures if it's not treated. So a couple things to think about there when you're talking about like environmental emergencies and industrial exposure. Again, here with most all of these, the primary treatment is going to be high flow oxygen. If they are not breathing enough to sustain life, then you start assisting their ventilations. Don't forget that the bag valve mask can be used for more than just a non-breathing or apneic patient. Somebody who is having difficulty breathing, you can use a bag valve mask to assist their ventilations. We'll talk more about that in class. We'll actually do some of that so you can kind of get an idea as to how that works. The remainder of the stuff on this document, you're more than welcome to read. I've covered a whole lot of it, so hopefully in this short 30-40 minute section, it really helped drive home some of the points in the respiratory emergencies and helped clarify some stuff. As always, reach out if you have any questions. If I've confused you with something, please let me know, and I will do everything I can to try and unconfuse you, or we'll find somebody that can help you. Hopefully it's me, but you never know. So anyways, thanks. I look forward to working with you guys again.